AFFRM AI at its core is really about providing a tool and structure that can help guide the assessment of responsible and equitable AI systems within healthcare. So we're obviously going to talk about the framework today, but we're also going to be touching on the importance of using judgment in these scenarios as well, because as much as structure can help, in order to truly safeguard against unavoidable biases and inequities, we really need to be pulling on our expertise and our judgments. And the conversation today is going to wrap up with our team's next steps and what we're hoping to do in order to move this project forward so it can be operationalized and have a bigger impact at UHN and hopefully more broadly as well. We'll have plenty of time for questions at the end. We made sure that there was lots of discussion time. But with that, I will pass it over to Christopher for the first part of the talk.
Wonderful. Thanks, Matea. And as Matea said, thank you all for being here. We're really excited to talk about this. So before we jump into the framework that we've developed, let's talk a little bit about what the framework was trying to achieve. We all know, if we're here, that there are biases in our healthcare practice and in our healthcare data. So inevitably, if we are training models and implementing AI solutions based on that data, there's going to be bias. So the goal to address that is to develop AI that we can consider fair and responsible. For our purposes, we're defining fair AI as a system that returns minimally prejudiced results. We recognize that it's not likely possible to remove every ounce of bias from a data set, but minimally and acceptably, and minimizes unjust differences between populations or people for whom the AI is being applied. Responsible AI for us means that we are applying AI in a just and proportionate manner. We're not replacing doctors, nurses, or anything like that with AI. We are letting AI be a support to our clinicians and clinical staff. And very importantly, for our AI to be responsible, it of course needs to be accountable and transparent. We need to have clear ideas of who is in charge of this AI, who's in charge of its findings, who's in charge of making sure it stays up to date and compliant with governance, and so forth. So how do we actually achieve that? The idea behind our framework was to identify domains that need to go into fair and responsible AI. The first, and I think most obvious right off the bat, is bias identification and mitigation. Of course, we need to be able to identify if there's social or societal inequities that are present in our data set or in our healthcare system and mitigate it. And we also need to understand how the data itself might have methodological biases and how to mitigate it. The second is stakeholder engagement. So of course, if we're going to develop a system that works for everyone, then we need everyone in the loop as we're developing it. This includes end users such as admins, nurses, clinicians, clinical staff, as well very critically as patients and caregivers who will be affected by the AI solutions. And the last thing that we need to wrap in is system support. We need to have pipelines developed for our AI systems that are auditable. We need to understand when they need to be flagged to get looked at closer, to maybe update or decommission. And we also need to support the people who are using this AI solution with education platforms and documentation. This all leads to better accountability, where we can understand how this AI solution needs to be updated, who's responsible for updating it, and how we can make it proportionately applied throughout its life cycle. So having identified these domains, of course, we went to the literature and said, what guidance already exists? This project was started about 2 years ago, and at the time we did a relatively thorough scoping review of the literature. We recognize that there are probably hundreds more frameworks that have been developed in that time. So the couple of things that I'm going to talk about today were relevant back then, and they continue to be relevant now. At the time, the frameworks that we identified largely focused on the ideas behind fair and responsible AI, the ethics, the goals that you might have, but less the tangible actions that you would take to reach responsible and fair AI. Other frameworks that we looked at, for example, the CHAI framework, were really focused on commercialization, whereas we're focused more on fundamental research. So basically, we found that many of these frameworks had either relatively niche audiences, or they were really academic or legalese focused and not so much tangible for people who are putting AI into practice today at UHN. With that in mind, we thought, okay, can we develop a framework that helps us guide our community towards fair and responsible AI in a way that is specifically applicable to the Ontarian context, to the Canadian context, and here at UHN? So as Matea alluded to when we started, we are representing a much larger group that we brought together as a working group to do this synthesis and recommendation process. We had people representing legal, bioethics, education, IDEA, AI scientists, data scientists, and clinicians. And we also had people primarily from UHN, but also from other GTA institutions like Sick Kids and York University to get a really GTA specific focus on how we can develop a framework that helps us be fair and responsible. So that's a little bit of the background of how we developed this framework. Now I'm going to walk you through what we developed. I'm going to caveat this by saying I'm not going to spend a huge amount of time on this. There's lots to read on this slide. It is published and available, as you can see on the hyperlink down at the bottom of the slide on the CDI website. We are also going forward, as Matteo will talk about later, going to have educational workshops around the framework. So instead of walking you through every single slide, every single section, instead I'm going to highlight sort of our thought process behind it and some of the most critical inflection points that we added. So as you can see from this framework, we have sections that are divided into the stage of a project that you might be in when applying an AI solution. The very first is, of course, problem identification and study design. Within these sections, we have areas that we flagged with checkboxes as well as stop signs. The checkboxes are areas that we highly encourage each team to consider, and the stop signs are areas that are critical inflection points that must be documented and auditable in the future. In problem identification and study design, the first thing that we, of course, flag is that a team should be defining their problem specifically and clearly. What clinical issue is this AI solution going to solve? Or what administrative issue or documentation issue is the solution going to solve? It should be articulatable for the project team. If this AI is applied, what decision point changes? Where is this technology coming in? And what is our expected outcome? The other thing that's really critical about starting a project is, of course, to assemble an interdisciplinary team that can help with this consultation, both at the beginning, defining your problem, and throughout in evaluating your solution. When we say an interdisciplinary team, what we believe is important is, of course, clinicians, clinical end users, data scientists, and researchers, but also patients and caregivers, legal experts, privacy, security experts, bioethics experts, and so forth, as relevant to your project. The other thing that I want to flag about this section is that we developed this framework primarily thinking about an AI that is built from scratch at UHN and then deployed. But the vast majority of these steps are also applicable for an AI that you're procuring. If you procure an AI solution and you intend to deploy it at UHN, you still need to have, for example, a clear idea of exactly what decision point it'll be affecting. So that's the problem identification and study design phase. In the model training and development phase, which is really applicable to if you're building an AI in-house, one of the biggest questions that we ask is this data fit for purpose? Presumably, if you're building an AI here at UHN, you're mining the electronic health record, clinical notes, images, lab values, etc., to build a solution that is predictive or analytical based on some problem. The questions you need to ask yourself in this case are, is this data what I expect it to be? Do I have as much of it as I expected to? Is it where I expected it to be? Is it coded the way I expected to be? And also, is there differential missingness? For example, what are the type of patients that are likely to be at a tertiary care center at UHN? Is that the same type of patient that this problem might affect if they were out in Barrie? Following model training and development, we have a section on clinical evaluation and also a section on silent deployment. These to us are similar in that they are looking at how this AI is going to be deployed clinically, but they're slightly distinct. Silent deployment to us is validating. Does the model behave on your prospective clinical data the way you expect it to? So you're not actually putting the AI system in use, you're not having people respond to it in any way, but you are evaluating prospectively, does it work the way we thought it would with the data that we currently have in clinic. And so here, one of the really important stop points is, does it meet the equity and fairness objectives that you've defined in real world data? Clinical evaluation, which takes it slightly further, is if your team has decided, yes, it works the way we want it to, it's outputting what we want it to at the rate we want it to, it meets our objectives, then we can go on to evaluate, does it actually behave in clinic the way that we expected? For example, if you had a clinical decision support tool that was going to flag people who needed a more urgent CT scan, when you put it into clinical evaluation, you might say, are people actually acting on that recommendation at an appropriate rate? That would be a clinical evaluation. In the final section of our framework, we talk about operational deployment and lifecycle monitoring. This is past the point at which you're evaluating whether or not your AI system works, and instead you're looking at how should we maintain it long term. One of the most critical components of lifecycle monitoring from our perspective is, if you continue to audit your AI solutions objectives, your equity objectives, and your fairness metrics, what happens when it no longer beats those targets? Either due to data drift, change in clinical practices, change in governance around AI, you need to be thinking long-term about who is responsible to update or decommission this AI solution. So that's a little bit of a summary of the framework as we conceptualized it and as we put together. One of the things that I want to flag is that this overarching view of points that you need to consider is not the only resource we provide. Because what we recognized from other frameworks was that the real lack was tangible site-specific recommendations, we've also developed an appendix where every point on the framework has an associated appendix entry that provides more specific examples and UHN-specific examples of things that you might need to consider. So as just one small example of this, if we look in the silent deployment, where our stop sign says, is your prospective data representative of your retrospective data? In our appendix, we flag, as many of us know, that UHN changed its electronic medical record system from EPR to EPIC in June of 2022. The reason this is an important flag is because if you trained your model with data primarily pulled before 2022, and then you're intending to deploy it in the clinic post 2022, which is any time now and going forward that we're going to be deploying it, you need to be aware that the way the data is being stored, the types of variables that we are collecting and the names of them and so forth might have changed. And so this is something that is UHN specific that we would prompt people who are going through this framework to consider. Okay, so that's a little bit about our framework. Now I'm going to pass it back to Matea to show you more tangibly how might this framework be applied? How does it support responsible AI?
Great. Yes. So I'm going to be showing us how you can actually use the framework as a structure to guide you through a problem you might be working on. And so for some context, the project that I'm about to show you is a type of project that came across my desk within CDI. It's a collaboration with the BHK lab, but it was one of those projects that came across that really helped motivate the need for this type of framework that we've developed. And so the clinical context for this question, it's within the realm of developing an AI system for radiation therapy contouring, specifically within head and neck cancer patients. So when a patient comes in for radiation therapy, we need to not only define where the tumor is in 3 dimensions, but also where surrounding organs at risk are. Reason for doing that is we want to minimize the radiation dose that's going to those organs at risk while maximizing it to the tumor. This is traditionally a manual process that's very time consuming and also has a lot of variability depending on who is doing the contouring, both inside of an institution, between institutions, or across different countries as well. There might be different requirements for these types of contours. So many groups, like I mentioned, including Benjamin Habe-Cates' lab, have developed different AIs for this. There's a lot of commercial products as well for this now. So what we wanted to do was test these AI models to see how they might function and also to probe them for different inequities and biases. The ultimate goal and the ultimate clinical decision point being, can we reduce the time needed for a clinician to develop these different contours? And so when we come to our framework, in this scenario, I'm going to start off in the model training and development part, specifically at the point at which we recommend defining your different equity and fairness metrics. And so we had this larger graphic, which then goes to a more detailed table, which again then jumps to our appendix. And within the appendix in this scenario, we give a few different examples of what a fairness metric might look like. And so the one that we decided to look at for these different OAR contourings was, can we see if these models are group unaware? And what that means is that a model does not use sensitive information during the prediction or the output of that AI system. And this can be tested using a simple linear regression. And so that is exactly what we did. We did a screening test of different organs at risk, which you can see along the y-axis for head and neck cancer patients, against different sensitive attributes. So age, disease site, HPV status, and the sex of our patients. These little red rectangles indicate scenarios where the sensitive attribute of a patient and a different organ at risk are tied to that sensitive, or tied to the model's performance at a significant rate. So that's a p-value of 0.05 or less. And in this case, today, I'm just going to walk you through because there's a lot of them. So today, we're just going to focus on specifically the mandible bone, so the jaw of our patients, as well as the sex of our patient and how those might be tied together and considerations that we might have. So using an internal data set, similar to what was used to train this AI system, we divided out the performance of the model into male and females. And when we plot this, there is a significant difference in the model performance for these two different groups. So our p-value is less than 0.01. It's a little hard to see, but I do want to point out in this scenario, lower is actually better. So the lower the number, The number corresponds to how much time would be required for a clinician to correct an AI-generated model to a level at which it could be used in a plan. And in this scenario, female contours are actually having a better performance than male contours. And this is two important things tied to it. So if this AI were to be deployed without correcting this, it means that contours for males of the mandible are at a higher risk of toxicities. But it also means that our goal of speeding up contouring wasn't met. Because in order to make these clinically acceptable contours, a clinician would then need to come in and correct it. So we might actually be adding time to this scenario. We wanted to see if this held as well across external data sets, because a very common thing is you develop a model internally and then you want to see if it's generalizable. And we did have access to two external data sets. So furthest here on the left is our internal RADCure data set. In the middle is TCIA HNSCC, which is from MD Anderson. And then we have a radiomics QC data set, which is from 4 different institutions across Quebec. And this sex bias held, the significance held for 2 data sets. So our RADCure data set, which we already knew, and our Quebec data set. So the MD Anderson data set didn't have a significant bias between the sexes, but something that's interesting is when we standardize the y-axis, you can see that there's a drift in overall performance between these data sets. And so what this means is that there's a potential institution-specific bias that's occurring. And this is something that's really important to note because, as I mentioned, we want to send our models out, but similarly, we're bringing models in that have either been trained by other research institutions or we are getting them from different commercial groups as well. And so if they're trained on data that isn't representative of our population of patients, there's a really big risk that we aren't going to be getting the performance that we want to out of these models. And we do risk different biases that we might not be accounting for. So with this in mind, when we go back to our framework, we've defined our equity objectives, we've assessed them within our model. And the next thing we do is we come down to this stopping point where you want to see it's the final question of, does your model meet these metrics? And in our case, it's very obvious that we don't. We do not have an unbiased model when we look at the AI system that we were using. And so the recommendation is to consult with a cross-functional team. In this scenario, we were looking to consult with rad-oncs, radiation therapists, radiation planners, AI specialists, and patients. And the goal of doing this consultation with the cross-functional team is to decide whether we want to stop this project, whether we want to try to mitigate the bias, or whether we want to go back to the drawing board and seeing if there's a different way that we want to handle this. And so what this is showing is that judgment really is embedded into each of these different stages of the project. We needed judgment to decide what fairness metric we wanted. We now need judgment to decide if we want to continue on in the project. And so this is a really important aspect of this framework, which is really just there to provide the structure and some guidance. And so I'd like to pass it back to Christopher now, who's going to walk us through a couple of the really important places along the framework that requires judgment that we think that we should all be aware of.
Perfect. Thanks so much, Matea. So yeah, where do frameworks struggle? I think we can all recognize that AI that is responsible, trustworthy, fair, and so forth requires not just the structure to tell you where you need to be looking, but the judgment to decide what to do with the information you're looking at. In the very beginning, first we have to start with, what are we even talking about when we're talking about AI? And in here, I'm talking specifically about AI in healthcare. If we're going to apply an AI framework, we should probably have a good sense that we're working with an AI solution. The potential for harm increases as we get closer to patient care. If we're talking about a tool like a smart fridge, there's probably a relatively low chance that you harm patients, although not zero. We all probably read an article about one of the hospitals that was hacked through a smart thermometer in a fish tank in the hospital lobby. So this isn't to say that we should outright discount tools that don't touch patients at all, but I think it's easy for us to understand that if you have an AI that's, for example, helping with triage in an overcrowded emergency department, that's going to be much higher risk if the AI misfunctions or doesn't function equitably. As if you're working with one of these tools. So the first thing where we really need judgment is when you stop and ask yourself, is this project that I'm working on AI? And is AI the most appropriate or feasible solution in this space? There should be a thorough assessment of the pros and cons, not just in terms of the harm that may or may not be done, but also in terms of the time and money investiture if you're bringing in an AI system, the environmental impact, and so forth. So this is the sort of first stopping point right at the very beginning of starting an AI project, where a team needs to be consulted and a judgment call needs to be made of, is this AI, and is this AI an appropriate one to apply? Moving forward, we also have the challenge of incomplete and evolving evidence. So if we decide we're going to move forward with an AI solution, I would hope that one of the first things that people would do, and what we prompt you to do in the framework, is a thorough literature search to understand what do we know about the disease or the patient population or the scheduling problem that we're trying to address, where are there already biases that have been identified and how can we mitigate those. And that's a wonderful first step. That's where the structure really tells us this is what we need to look into. The judgment comes in the fact that there is always going to be incomplete literature. Even if it's the most researched disease on Earth, there are still going to be specific lived experiences that aren't captured. There's still going to be evolving clinical practices that make that literature not relevant in 5 years, and so forth. So having someone who's really able to say, hey, I worry that X population isn't represented in the literature, or I know that X population isn't represented in the literature, is a critically important judgment when we're contextualizing for ourselves where are the pitfalls that our AM solution might encounter. But even if we had the perfect literature and the perfect understanding of the disease and the population that we were working with, there would still be issues with data quality. As I alluded to earlier, most of the time when we're thinking about developing an AI system here at UHN, we're mining observed healthcare data, the electronic medical record, notes, lab values, and so forth. However, as much as we would like to think that that is a perfect source of base truth, there are many issues that come with the data that we collect. One of the first ones is data missingness and incorrectness. I think it is clear to most of us that not every clinician or nurse can write down everything that they experienced in every clinical encounter. And so depending on the type of information you're trying to mine, there might be a lack of data on, for example, social history or previous medications that you would hope you capture, but you don't always. The other issue here is incorrectness. We're fallible, we're humans, we don't always write the right thing. To give you an example of this, my spouse is a biracial woman. She's half Chinese, half white. And when she was in the NICU after she was born, her clinical notes noted that her father, who is Japanese, was in attendance. He's not Japanese, he's Chinese and Taiwanese, but no one asked. They made an assumption, it was a stressful situation, and they wrote it down because they thought it would be helpful information to have. This could cause two issues. The first is if we use her data set to create a model, and we think that we should look at race and ethnicity as important factors, we would be incorrectly labeling her data as the experience of someone who is Japanese. The second is if we actually already had a model in play in this NICU context, and we were again saying, who needs higher surveillance, or who should we be giving this particular drug to, and we were sensitive to race and ethnicity as factors, she would be incorrectly flagged in that model and potentially not get the level of care that she should. So although these seem like very minor things, one time that we wrote down someone's ethnicity wrong, or one time that we didn't ask about their social history, they end up compiling into biases if we put these in AI solutions that we use moving forward. Another issue is, oh, sorry, could you go back, Matea? Our coding and documentation practices. So it is very likely that the way that we document will shift over time. For example, currently, if you have someone who's being assessed for a heart transplant, you're probably going to do a very in-depth social history assessment. If you have someone who's being assessed for coronary artery disease, you might not. That may be appropriate, or maybe in 10 years we'll find that actually the level of social support you have is one of the most important and influential factors in your coronary artery health. And so the documentation density might change over time. Additionally, we change with our ICD-10 codes, we change the EMR that we're using and so forth, such that the same variables or information that seems relatively stable might change over time. And lastly, we have structural access and historical inequities. We know, for example, that there are many clinical predictive tools that we currently use that have historically been race corrected. What that means is, for example, if we're calculating someone's estimated glomerular filtration rate, if they are Black, we might calculate it with a slightly different equation than if they have any other racial or ethnic identity. This has recently been proven not to be helpful and in fact to be harmful, but what it means is that the historic information that we have for Black populations vastly underestimates the rate of chronic kidney disease. So if we were now going to build a model and we said, we want to take historic data from the past 20 years and use those outcomes to predict who needs the most aggressive kidney care in the future, we would again be coding this bias that we accidentally had previously into the future generation of tools that support CKD evaluation. Okay, so that's a challenge in and of itself. The other thing is that there are going to be many variables in the EMR that appear neutral, right? Someone's disease stage, the frequency at which they go to the ER. But we know that if we actually look close at these tend to proxy for other inequitable factors. For example, we know that someone who lives rurally or remotely is likely to present to a large tertiary care center at a more advanced stage of disease than someone who lives right next door. Similarly, someone who uses care very frequently likely has closer geographic access, social access, economic access than someone who doesn't. And so even when we're choosing variables that we think are going to be relatively neutral and relatively close to base truth, we need to do a deep judgment on whether or not these are as neutral as we thought and how we can mitigate the fact that they might encode bias. So that's a big challenge. We're asking a lot of people. We're asking them to functionally be experts across lots of different domains to apply fair and responsible AI. And of course, we don't want to do that without support. So again, part of the support we're providing is the structure and how to use it. And part of the support we're hoping comes from a cross-functional team put together for any AI solution applied here at UHN. I'm going to pass it back to Matea to talk about how we're hoping to put this tool in your hands for your projects moving forward.
Thank you, Christopher. Yes, so this has been a bit of a view of what we've developed so far. You can access all of that within the publication that we have, and I'll link it at the end of this presentation as well. And a lot of those judgment things we prompt you for throughout the appendix as well. But like Christopher mentioned, how are we going to bring this into our institutions now? And we're proposing to do this in 3 different ways. So the first pathway is by integrating this type of structure into existing oversight and review processes. The idea is to make this visible, not to make this a cumbersome process that's going to slow down innovation within the institution. The second is around training and shared practice. So providing opportunities to educate on this information and how to use this tool in a very tangible way. And the third and final pathway is through a technical system that's going to, we hope, allow us to scale and standardize elements of these assessments. AI is growing at a very fast pace, and it isn't necessarily scalable how we are currently doing our oversight of these systems. So we're hoping to develop a technical solution for that, which I will get into in a few moments. So to go into a little bit more detail on these, in pathway 1, the idea is, oversight is already existing within UHN for any research project or clinical change that is being proposed. It's a very thorough review process, as it needs to be, but the landscape is also changing rapidly in terms of our uptake of AI and how we need to start questioning these systems coming through. And so the idea is to enfold existing practices with some of these the AFFRM AI considerations. And so existing mechanisms might already be there for the REB during the proposal phase. Then you might go off, do your development of your AI system and your validation. Then you might be interested in the silent deployment component. So maybe you do a QI application. And all throughout this, we're also considering our deployment committees. And so because these exist already, we want to start bringing them into this space and partner with these groups to make sure that AFFRM AI is built into them and used consistently and early throughout the entire process. And so again, we consider AFFRM AI to be the structure and guidance for these existing processes. And work is already being done in these different spaces, which is fantastic. So some of the oversight tools that we're already seeing uptake some of this information is within the REB, specifically for an REB AI reviewer checklist. And this has been developed by Dr. Jen Bell, who's an ethicist at Princess Margaret. She was also part of our working group. And so the idea that she developed with the REB was to create an AI reviewer checklist, which meant that any project that came into the REB that had to do with AI there's going to be tangible things and questions that you can ask about that project. And the idea is to make sure that we are adequately assessing these systems, but also to have more informed questions back and forth with these different developers and applicants. Now, the second place that we're seeing this in parallel is with Kelly Lane through the AI Hub and through the Deployment Committee. And they have developed something called the AI Intake and Risk Assessment Form. And there's an explicit question within that form around bias and inequities, asking whether an adequate assessment has been performed on this given system. And so we're working with them to help define what an adequate assessment would actually be. And this means that we are going to have more consistent expectations for both reviewers and applicants. We're going to have better alignment of approvals because there's a potential to remove different redundancies across different applications. And really importantly, this means that there's going to be easier governance reference for these different systems going forward. By having these very consistent expectations at different levels, a lot of AI systems are going to require very frequent auditing as they go through their life cycle. And so by having these historical documents, we're going to be able to reference them a lot more easily. Now, Pathway 2 is really about focusing on people in practice and the education components that need to go with this. So within our group, the goal is to run 2 different workshops with different pathways aligned to various aspects of the framework. The framework is very, very broad, and so we want to be able to tailor the information that's important to different groups. And those 2 different groups that we're looking to help out are the oversight and clinical teams, as well as the more technical and data science teams. Now, it's important to note within these workshops, we don't have a goal of turning everyone into a bias expert. That's not a feasible thing. The goal is really to create a shared language and consistent expectations around what responsible AI looks like in practice. And this will hopefully help inform the development of these responsible systems, but also expedite the approval and oversight of these systems as well. Now, the third and final pathway is around supporting scalable oversight of these AI systems. So oversight, review, and training are essential, but they aren't going to scale indefinitely, which is a really important thing in these days. So our models are becoming more and more complex. They're going to require more frequent updates. They're operating across diverse populations and workflows, and it's becoming very difficult to rely solely on periodic and manual bias assessments. And so this is what is really motivating this third technical pathway. So namely, we're looking to develop an agentic identification system for disparities and inequities. So agentic systems are all the rage right now, and likely for good reason. They do have a lot of potential if they're done well. And so with this system, rather than focusing on a single stage of the AI system, we're hoping that it will be able to look at all aspects of an AI system as we go throughout its life cycle. So within our agentic system, we'd obviously have a coordinating agent, but then the goal is to also have a data context agent. And this would be able to go through your data, historical data or prospective data, and see again if it's fit for purpose. What is the quality of the data? Are there any historical biases present? How's the missingness, if any? And really start to try to quantify the data quality that is going to then be used within the model, either for training, for validation, or within the actual clinical use of it. The second agent would be around disparity evaluation, so a disparity evaluation agent. And this is similar to how we assess the bias within our contouring AI system that I showed before. So we would be looking to see if there were any discrepancies or disparities in the model performance across different subgroups of patients. We can also do different targeted perturbations of different AI systems as well to try to see if there's other things that are embedded within an AI system that perhaps we aren't getting at by looking at different subgroups of patients. And then finally, there would be an interpretation and reporting agent. This would be potentially a simple LLM that would create a summary report of any disparities that were found within our data context agent or our disparity evaluation agent. And it would output this in a report that could be used by both technical staff as well as oversight staff. And so this allows that common language between the groups, and it provides, again, a consistent source of information about these different types of issues that you might run into with your AI system. And so it's important to note, though, that this is not meant to replace oversight in any way. It's really just meant to be there to help scale this process. Because if you have a consistent report coming across your desk, it's going to be a lot easier to know how to correct this AI system or how we might need to change our oversight of it. Now, this is not something that we're building from scratch. Through a collaboration between CDI and the AI Hub, we developed something a little while ago called the OncoJarvis system, and it's an AutoML pipeline that has a data analyzer, a model trainer, and an explainer. And so I'm going to show you now an example of how these reports look right now. They would be different within our new system, but it will also demonstrate some of the issues that might come up and some of the judgment that might be required. So using a variety of different head and neck data sets, we looked at them through our analyzer. This is a little small, but if you look in this section, it shows potential outliers in this data set. Specifically, the system flagged a specific case for T stage, RT0. Now, in head and neck cancer, that does mean a recurrent T0 stage disease. But this is where the judgment comes in. You need to then actually know that. You need some clinical context. You need to understand the clinical question that you're asking and whether that's relevant, because this could potentially be a misspell. It could potentially be something that is not relevant for this question. And so we're able to flag that as a potential outlier in this scenario, and something similar could be done with our data context agent. An even more interesting one is when we try to look at model bias assessment. And so a simple model was fit based on survival within this data set. And if you look down here, one of the findings is that non-smokers exhibit a reduced hazard, so improved survival, which makes a lot of sense. Smoking is not a great habit, and so it's going to affect our survival, particularly within head and neck cancer. And this is obviously a true statement for these data sets. But if we again think about how models are not traditionally, but sometimes used, we want to then check their generalizability to other institutions or potentially other disease sites. And so there's an interesting thing that's happening where there's increased literature right now within lung cancer spaces that certain groups of non-smokers actually have increased risks of lung cancer. And so what this means is that this statement wouldn't hold true if we tried to deploy this model within a clinical setting for a lung cancer patient. So again, this is where your judgment is coming in. And so this is just to show that our AFFRM AI system is there for the standardization and the reporting and the structure, but judgment is still paramount in these types of questions. Now, I'd also like to highlight two other projects that CDI has right now within the clinic. There are various stages of deployment. So we have our Aim to Reduce project, which was developed alongside Dr. Robert Grant. It's around ED visits, and it's a warning system for gastrointestinal cancer patients. It's in our silent mode right now. It should be entering clinical evaluation within the week, I believe. But this is allowing us an opportunity by having these types of projects within silent mode to look at how we need to update these models and at what frequency. And we're learning how we're needing to assess different data drifts that may or may not be occurring. And that will ultimately help us inform our agentic system when we start building it. Miracle is another project that we have. This was developed along with Drew Hope and Tony Tadich, and it's around inflammatory lung disease and a warning system for radiation therapy planning to highlight when patients might need further consideration because they might be at higher risk of toxicities. This one is in our clinical evaluation stage. And again, it's providing those opportunities where we can learn from the information to see how these different data drifts are affecting the model. And because we're in clinical evaluation, it also provides an opportunity to see how people are acting on this model, because that's a really important component as well. Not only the performance of the model, but is it actually adding something to the clinical process that is a net gain, or is it something that we need to think about removing from the system, either because it's not being helpful or it's being cumbersome to the actual clinical process? So with this, I'd like to thank you all for sticking with this afternoon. We really hope that we were able to present to you the AFFRM AI framework in a way that you come to understand that it's really there as a practical and flexible structure for any type of AI healthcare assessment to make sure that we're developing the most responsible and unbiased systems that we can. And we also hope that we were able to portray to you an appreciation for and the importance of judgment alongside this structure. Because for responsible and ethical AI to happen, they can't exist in isolation. We need both. And so as we move forward with this project, as I've just covered, we're really hoping that we can have a big impact by implementing into AI oversight structures, by providing these different workshops as opportunities to learn and practice alongside this AFFRM AI framework, and then also the development of technical systems that will hopefully expedite and scale these different ideas as this field continues to grow. We are a very large team, and we're always looking for additional members who might be interested in joining. So we'd like to acknowledge everyone who's been involved in this project thus far. We are growing, so if you do have any questions, ideas, if you would like to get in touch with us, there's a couple different ways. So the work that Christopher and I have presented today, it was published in Lancet Digital Health recently. And so you can access that here. We also have a framework website where you can go. It also has access to our manuscript, the appendix that's associated with the manuscript, and there is a sign up for the workshops that we will be hosting. Announcements for the workshops will be coming out in the fall, but if you're interested in joining, there is a link here, and I think I can provide it in the chat as well. To sign up, we need your name, your email, and what workshop you would be interested in. And again, if you have any questions, please feel free to pop them in the chat, raise your hand, or if it comes to you later, you can reach out to Christopher or myself at our emails here, or this is the CDI email where we can be reached as well.